Good day, everyone. This is Dr. Von, and for this week, we will be discussing about your calcium ion. So this is already a correlation of what we learned during the parathyroid gland discussion. For this week's learning objective, we will be able to discuss about your calcium body distribution. What is the function of your calcium? And how do we regulate your calcium using those three important hormones? The synthesis and action of those hormones regulating your calcium ion, specifically your parathyroid hormone, your calcitonin, and your vitamin D. Then, the action control for calcium, the clinical significance or the different disorders relating to your calcium level, your hypocalcemia and your hypercalcemia. And then the different laboratory methods and interpretations. Your calcium is said to be the fifth most common element in the body. It is actually involved in enzymatic activity or enzyme activity. Remember that your calcium can also act as a cofactor. It is also part of your blood coagulation system, specifically your blood clotting number 4. Clotting number 4, which is your calcium. It is also involved in your excitability of skeletal and your cardiac muscle. Once your calcium is being released by your smooth endoplasmic reticulum, it will then attach to the microfilaments of your skeletal and your cardiac muscle, causing contraction. It is also involved in the maintenance of your blood pressure. So your calcium, 99% of this is actually found in the bone. 1% is found in the circulation and in your extracellular fluid. 15% of your calcium is bound to anions to your citrate, bicarbonate, and lactate. And 40% is bound to your protein, most specifically in your albumin. Only 45% is free or ionized calcium. The concentration of your ionized calcium in blood is 5,000 to 10,000 times higher than in the cytosol of cardiac or smooth muscle cells. Maintenance of this large gradient is vital to maintain the essential rapid influx of your calcium. According to Rodriguez, among the three forms of this ionized calcium, your ionized calcium is the sensitive and the most specific marker for calcium disorders. So this diagram will show us the distribution of your calcium. Again, this is the fifth most common electrolyte in comparison to your sodium, potassium, chloride, bicarbonate, and other substances. So you see your calcium, your blood plasma is approximately, the calcium is around 5 milliequivalents per liter. Your interstitial fluid is around 3 milliequivalents per liter, while your intracellular fluid is only around 0.2 milliequivalents per liter of your calcium. So your ionized calcium should be maintained at near normal levels during surgery and in critically ill patients. Why do you think? We have to check first the serum calcium of our patient prior to surgery because a decrease of your ionized calcium can impair myocardial function. There could be cardiac arrhythmia if the patient has a low level of your serum calcium. A decreased amount results in impaired myocardial function and neuromuscular irritability. There could be irregular muscular spasms or your tetany. That's why prior to surgery, guys, it is prudent really that we have to check for your serum calcium. So in terms of regulating your calcium ion, there are three important hormones which regulate it. Number one, your parathyroid hormone, which is secreted by your parathyroid gland. I guess we already discussed your parathyroid gland or your parathyroid hormone. So I want you to review again the parathyroid gland so that we can correlate it to your vitamin D and your calcitonin. For this discussion, I will discuss more the vitamin D and your calcitonin because sa parathyroid hormone na-discuss na natin to. So just watch again my video lecture of your parathyroid gland. So these are the three important hormones that regulate your calcium, your PTH, your activated form of your vitamin D, specifically your 1,25-dihydroxycholecalciferol, and lastly, your calcitonin. So your parathyroid hormone is produced by your parathyroid gland. Your vitamin D, we will see where just your vitamin D is being synthesized. And lastly, your calcitonin is being secreted by your thyroid gland. Very good. So first, let's just have a short review of your parathyroid hormone. Again, your parathyroid hormone stimulated by decreased ionized calcium. So once there is a decreased level of your serum calcium, your PTH will be released. So it has two important actions, sa bone and sa kidneys. Sa bone, anong ginagawa niya? There will be bone resorption, in which activated osteoclasts break down and subsequently release your calcium into your ECF para tumaas yung calcium level. In your kidneys, it can cause conservation of your calcium, or it conserves your calcium. There also be renal production of your active vitamin D. So sa kidneys, pinapataas niya, increasing tubular reabsorption of your calcium ions. Now let's proceed with your vitamin D. So your vitamin D, which increases your calcium absorption in the intestine. So ang action naman ni vitamin D is towards your intestine. Increases calcium absorption. It also enhances the effect of your parathyroid hormone on your bone resorption. So si parathyroid hormone and vitamin D, ang main effect talaga nila is to increase your serum calcium. So the activated vitamin D3 is obtained from the diet or exposure of skin to sunlight. Your vitamin D3 is then converted in the liver and still in active form of your vitamin D. However, in the kidneys, your inactivated vitamin D3 is converted into its activated form, which is your 1,25-dihydroxycholecalciferol. So let's check this diagram. Again, your 7-dehydrocholesterol in your skin, by the action of the UV rays B of your sun, converts this 7-dehydrocholesterol into its pre-vitamin D3, which is your cholecalciferol. Again, ang 7-dehydrocholesterol na matatagpuan sa ating skin by the action of your UV rays B will be converted into pre-vitamin D3, which is your cholecalciferol. Your cholecalciferol will undergo hydroxylation by the action of your 25-hydroxylase, making now your cholecalciferol into 25-hydroxy-vitamin D3 or your calcidiol. But this calcidiol is still inactive. It needs to go to the liver to become biologically active. In the kidney, by the action of your 1-alpha-hydroxylase, the 25-hydroxy-vitamin D3 is now converted into its biologically active form, which is 1,25-dihydroxy-vitamin D3. So yung 1 dito nanggaling sa liver na hydroxylation, yung 25 dito nanggaling sa hydroxylation sa kidney. That's why it's di kasi twice na nangyari ang hydroxylation process. It is now called your 1,25-dihydroxy-vitamin D3 or your calcitriol. So anong effect ng ating calcitriol sa ating katawan? First, small bowel or small intestine calcium absorption, which is the main net effect of your vitamin D3. There could also be renal calcium reabsorption, bone calcium release. It also affects approximately 2,000 genes, regulation of your cell proliferation, and affects every tissue, including your brain. It also affects your leptin signaling. So your leptin signaling has something to do in decreasing your appetite because the function of your leptin is actually produced by your fats, and this leptin will cause now the suppression of your appetite. But our main concern here is always all about your calcium absorption. Yun yung dapat nating malaman. So again, your vitamin D, it's a lipid-soluble hormone that binds to a typical nuclear receptor, analogous to your steroid hormones. Remember, your vitamin D is a sterol, comes from your cholecalciferol. It's a sterol, similar with your sex hormones, similar with your thyroid hormones. Since it is a lipid hormone, it will go directly into your nuclear receptor. Because it is lipid soluble, it travels in the blood bound to your hydroxylated alpha globulin. There could also be extrarenal sites of the active form of your vitamin D. So, si active form ng vitamin D hindi lang matatagpuan sa ating kidney, but it will also be found in your placenta and your granulomatous tissues. Why do you think merong tayong active form sa extrarenal site na placenta? Because of the growing fetus. The growing fetus needs a lot of calcium for growth and development that will be supported by your vitamin D. What are the effects of your active form of your vitamin D3? Of course, it promotes intestinal absorption of your calcium. It causes synthesis of calcium-binding protein and related facilitated transport. It has also slight effects to increase calcium reabsorption in kidneys. So, meron din siyang effect patungo sa ating kidneys to increase your calcium reabsorption. Again, it works with your PTH to cause calcium resorption from the bone, which activates your osteoblasts to activate osteoclastic to resorb your calcium. We have different laboratory methods to identify our vitamin D3. However, your 25-hydroxyvitamin D or your inactive form of your vitamin D is a better marker since it has longer half-life. So around 2 to 3 weeks versus your active form, which is only 5 to 8 hours. So the reference method that we do is your dual mass spectrometry. Still, you're following the principle of your absorbance. The values are influenced by sunlight exposure and latitude. So there are around 35 metabolites of your vitamin D2 and as well as your D3. However, there are only 2 clinically important. So this is now the review of how your parathyroid hormone and your vitamin D increases your serum calcium. So sa intestine natin, yung parathyroid hormone, wala siyang action. Ang vitamin D, increase calcium and phosphate absorption. Again, vitamin D, increase calcium and increase phosphate. Tatandaan natin yun. So, si vitamin D, papataasin ang calcium and phosphate. How about sa kidney? Your parathyroid hormone causes increased calcium reabsorption, decrease phosphate reabsorption, and increase active vitamin D by increasing your alpha hydroxylase. Sa vitamin D naman, sa action ng kidney is to increase your calcium and phosphate also. So sa vitamin D, walang pili. Calcium and phosphate ang kanyang pinapa-increase and also increase urinary calcium. Your bone can cause, ang parathyroid hormone sa bone cause calcium and phosphate resorption. How about sa vitamin D? At normal levels, calcium and phosphate deposition. However, at high toxic levels can cause calcium and phosphate resorption. So now, what is the net effects of our parathyroid hormone and vitamin D sa ating blood? Some parathyroid hormone will generally increase your serum calcium and decrease your serum phosphate. Si vitamin D naman, again, increase serum calcium, pareha sila ni parathyroid hormone. However, it also increases your serum phosphate. Again, parathyroid, increase ang calcium, mababa ang phosphate. Si vitamin D, parehong tataas ang serum calcium and your serum phosphate. Si calcitonin naman. Your calcitonin originates in your parafollicular C cells. So remember, your calcitonin is being produced by your thyroid gland. It is secreted with a concentration of calcium increases hypercalcemia. So in short, pag mayroong calcium, tataas yung calcium level, your calcitonin will be stimulated because it inhibits the action of your parathyroid hormone and vitamin D kasi nga ayaw natin ng too much na calcium. So si calcitonin ang nagpapababa ng ating calcium level. Your calcitonin acts to decrease your plasma calcium levels, while your parathyroid and your vitamin D acts to increase your plasma calcium. Only calcitonin causes a decrease in your plasma calcium. So you already know about that. Calcitonin is synthesized and secreted by your, parafollicular cells of your thyroid gland. The major stimulus of calcitonin secretion is a rise in your plasma calcium levels. Chronic excess of calcitonin does not produce hypocalcemia. Kasi nga, di ba, calcitonin, ang effect ng calcitonin is pababain yung calcium. Pero a chronic excess of your calcitonin does not necessarily produce your hypocalcemia. And removal of parafollicular cells does not cause hypercalcemia. Again, it is still your parathyroid hormone and your vitamin D3 regulation dominate. Ang effect ng parathyroid hormone and your vitamin D3 is greater compared to the effect of your calcitonin. So for your laboratory methods for calcitonin detection, we have this pentagastrin stimulation test. Ano tong pentagastrin stimulation test, Doc? So we give pentagastrin via IV administration, approximately 0.5 microgram per kilogram body weight over 5 seconds. Then we collect the blood sample. Then we check for the baseline level, the levels after first, second, fifth, and 10 minutes of administration of your pentagastrin. The purpose of this pentagastrin, it is a diagnostic sensitivity for your medullary thyroid carcinoma is increased by pentagastrin stimulation before your calcitonin level testing. So this is now the interpretation of your pentagastrin test. Pag less than 10, normal, or 80% of the adults. If around 30 to less than 50, still around 5% of the normal adults could still be normal. But if it's greater than 50 to less than 100, or if it's greater than 100, there is already a possibility of your medullary thyroid carcinoma or other thyroid pathology. So in short, your pentagastrin has greater sensitivity in your medullary thyroid carcinoma. This is a form of thyroid carcinoma that is very aggressive. So this is now a review of the actions of your different hormones. So just a review lang natin. Your parathyroid gland, again, pag mayroong hypercalcemia, kakailangan pa ba natin ng maraming calcium? Of course, hindi na. So it will inhibit your parathyroid gland to secrete your parathyroid hormone. However, in cases when there is a low level of your calcium level, it will stimulate your parathyroid gland to secrete your parathyroid hormone. Kasi nga, ang effect or net effect ni parathyroid hormone is to increase your calcium level. In bone, it causes osteoclastic activity, releasing now your calcium and your phosphate group. It also, in the kidney, parathyroid hormone promotes absorption of your calcium, excretion of your phosphate, and activation of your renal alpha hydroxylase. This renal alpha hydroxylase can cause the activation of your inactive form of your vitamin D, which is your calcidiol. This calcidiol will be converted or can be activated in the kidneys. Then it will be converted into its active form, which is your calcitriol, which is 1,25-dihydroxy vitamin D. In the intestine, this activated vitamin D promotes intestinal absorption of your calcium and your phosphate, while in the kidneys, your vitamin D promotes renal reabsorption of your calcium and your phosphate. So this is now the summary of the regulation of those three important hormones. So meron din tayong, once your blood is acidotic or alkalotic, what will happen to our calcium level? Pag acidotic, it promotes the leaching of your calcium from the bone. So your hydrogen displaces your calcium from the protein. Pag alkalotic, ano namang nangyayari? It causes plasma protein to have greater negative charge, meaning mas nagbabind yung ating calcium sa ating protein. Pag acidosis, mas lalong natatanggal ang ating calcium sa ating protein. Pag alkalotic, mas lalong nagbabind ang ating calcium sa ating protein. So once there is acidotic or alkalotic, then there will be changes of your serum calcium. Again, ano nga nangyayari? Pag nagiging acidotic, mas lalong na di-displace ang ating serum calcium sa ating protein. Therefore, mas tataas ang ionized or free calcium. Pag alkalotic, anong nangyayari? Mas lalong nagiging negative charge ang protein, mas lalong nagbabind ang ating calcium sa ating protein. Therefore, bumababa ang ionized calcium or your free calcium. Let's talk about the different clinical significance of your calcium disorder. So for your calcium disorder, it is subdivided whether it is hypocalcemia and hypercalcemia. So these are the general signs and symptoms if patient is manifesting with hypocalcemia. We have your neuromuscular irritability. There could be paresthesia or numbness, pricking sensation, muscle cramps, tetany, and your seizure. So we have a test or physical exam that we do to our patient to detect whether the patient has your tetany or a low level of your hypocalcemia. Meron kaming tinatawag na Vostek sign. Ano yung Vostek sign, Doc? So this Vostek sign, we tap the masseter, the facial masseter muscle of the patient, and then when we tap it, then there will be cramps or contraction that will happen. So there is now a neuromuscular irritability. Pag sinabing Vostek sign positive, then that is a very good indicator that the patient has hypocalcemia. Meron kami isa pang ginagawa, your Trousseau sign. Sa Trousseau sign naman, nilalagyan namin ng BP cuff ang patient, parang binibipihan ng patient, tapos we will wait for a certain time, and if there is flexion of your wrist and extension of your fingers or contractions of your fingers, then that is already a neuromuscular irritability, which is a good indicator of hypocalcemia. There is also cardiac irregularities. That's why, kaya nga, prior to surgery, dapat there is normal level of your calcium because it can cause certain arrhythmia or heart block. And ayaw nating mangyari sa patient while ginagawa natin ang surgery. For hypercalcemia, there could also be a neurologic symptom similar with hypocalcemia. So this is very non-specific, and other GI manifestations which are also non-specific. For the renal, we have nephrolithiasis and nephrocalcinosis. Anong difference ng dalawa, Doc? Pag sinabing nephrolithiasis, these are actually your kidney stone. Pag your nephrocalcinosis or your Albright's calcinosis or your Anderson-Carr kidneys, it is actually a deposition of your calcium sa parenchyma sa kidneys due to your hyperparathyroidism. So in short, there is deposition of your calcium sa parenchyma mismo ng ating kidney. So mild hypercalcemia usually are asymptomatic. However, if you have moderate or severe hypercalcemia, then that's a time that the patient becomes symptomatic. So what's the difference between primary hypocalcemia and your secondary hypocalcemia? So ang difference ng dalawa, go back again sa ating mga na-review dati. Pag primary, saan nga? The primary organ that secretes your parathyroid hormone. So that's gonna refer to your parathyroid gland. So any problem that can cause destruction of your parathyroid gland, then there could be primary hypocalcemia. So what will be the serum level of your parathyroid hormone? Of course, the serum level of your parathyroid hormone will be low kasi nga primary hypocalcemia. Ang nagsisecrete ng parathyroid hormone is your parathyroid gland. Kung may sira sa parathyroid gland, hindi na siya makakasecrete ng ating parathyroid hormone. Mababa or low parathyroid hormone, therefore that's a primary hypocalcemia. Ano naman ang secondary hypocalcemia? So sa secondary hypocalcemia, okay naman ang ating parathyroid gland, nakakasecrete ng parathyroid hormone. However, the target organ of your parathyroid hormone does not respond to your PTH. It could be that it is resistant to your parathyroid hormone. Meron kang level ng parathyroid hormone, however, your kidney is being destroyed. Hindi siya makaka-absorb ng calcium. So what is the expected level of your parathyroid hormone? In secondary hypocalcemia, there is high level of your parathyroid hormone because your renal is resistant to your PTH. Sira kasi ang ating kidney kaya hindi siya nagre-reabsorb ng calcium. So as a mechanism, dapat taasan niya ang PTH. So that's your secondary hypocalcemia. Meron tayong tinatawag na muscle fatigue. So what is your muscle fatigue? Again, what is a normal muscle contraction? Once your calcium is being released into the cell, it will cause the filament in your muscle fiber, whether cardiac or skeletal muscle, to contract. Pag nag-cause ng relaxation, anong nangyayari dapat? Yung calcium dapat siyang nire-reuptake or nisa-store again, allowing the muscle filament to relax. However, if you have muscle fatigue, anong nangyayari? There is calcium leaking into your muscle cells. So, a calcium leaking or a tired muscle channel leaks calcium ions, weakening now your contraction. So, that's actually the pathophysiology of your muscle fatigue because of the leaking channels. Just remember that. So we have different clinical significance or disorders that will result into hypocalcemia or hypercalcemia. However, these different diseases are not pathognomonic, meaning pag sinabing hypocalcemia, hindi siya agad-agad na would mean a certain disease because there are a lot of diseases that we can relate whether it is hypocalcemia or your hypercalcemia. So hypocalcemia, again, your primary hypoparathyroidism, meaning may sira ang ating parathyroid gland. Pwedeng destroyed ang ating parathyroid gland or during surgery, meron tayong thyroidectomy or total thyroidectomy. And remember, your parathyroid gland is just located posterior to your parathyroid gland. So in short, the most common complication of your parathyroid or of your thyroidectomy is your destruction of your parathyroid gland. Pag nasira ang ating parathyroid gland, mababa ang ating parathyroid hormone, mababa ang calcium sa ating katawan. So that's why it's a primary hypothyroidism causing hypocalcemia. There could also be hypomagnesemia or hypermagnesemia, hypoalbuminemia, and other diseases. But I want you to take note about this hypomagnesemia and your hypermagnesemia. So kahit mababa or sobrang dami ng ating magnesium, it can still lead to hypocalcemia. How is that, Doc? How is that even possible, Doc? Once you have chronic hypomagnesemia, has also become recognized as a frequent cause of your hypocalcemia. Your hypomagnesemia may cause hypocalcemia by 3 important mechanisms. Tatandaan, it inhibits the glandular secretion of your PTH across the parathyroid gland membrane. In short, i-inhibit niya ang pagsisikret ng PTH, kaya mababa ang calcium level. Pangalawa, it impairs parathyroid hormone action at the receptor site on the bone. In short, sisirain niya or i-impair niya yung receptor site sa ating bone. Kaya kahit meron kang PTH, hindi pa rin gumagana ang PTH natin. Pangatlo, it causes your vitamin D resistance. You have vitamin D, but your vitamin D cannot act to its specific receptor. So that's why we have hypocalcemia in the presence of hypomagnesemia. Again, ano yung tatlong yon? Number 1, inhibit niya yung secretion ng PTH. Pangalawa, ini-impair niya yung receptor site sa bone ng ating PTH. Pangatlo, ginagawa niyang vitamin D, it causes vitamin D resistance. How about hypermagnesemia, Doc? An elevated level of your magnesium may inhibit PTH release and target tissue response, perhaps leading to hypocalcemia and hypercalciuria. So your elevated level also, ini-inhibit niya rin yung level ng ating parathyroid hormone release causing hypocalcemia. How about pseudo-hypoparathyroidism? In your pseudo-hypoparathyroidism, it is a rare hereditary disorders in which your parathyroid hormone target tissue response is decreased or there is and organ resistance. Again, you have a normal level of your PTH, kaya lang nagiging resistant sa PTH. Hindi gumagana yung ating mga specific organs specific for your PTH. Pseudo-hypothyroidism. PTH target tissue response is decreased because of end organ resistance. We have also other, how about for your hypercalcemia, Doc? So meron tayong primary hyperparathyroidism. So it could be caused by certain tumors in your parathyroid gland causing an excessive levels of your PTH. So pag maraming PTH, anong nangyayari? There could be hypercalcemia. Next, what else? We have also your hyperthyroidism, different malignancies such as your mga multiple myeloma, increased vitamin D, your thiazide diuretics, and your prolonged immobilization. The second leading cause of your hypercalcemia is associated with various types of malignancy, with hypercalcemia sometimes being the sole biochemical marker for the disease. So many tumor produce your ano nga yung hormone na pinoproduce ng ating malignant tumors kung bakit magkakaroon tayo ng hypercalcemia. It is your, ano nga yun? We discussed this in your parathyroid gland. It is your PTH-RP, your parathyroid hormone-related peptide. So this your PTH-RP, which binds to normal PTH receptors and causes increased calcium level. So your PTH-RP also resemble just like your parathyroid hormone, which also acts directly to your PTH receptor, causing increased calcium level. Kaya nagkakaroon ng hypercalcemia. So in patients with hypocalcemia, what are the common manifestations of patients with hypocalcemia? Of course, patients often have common physical features including short stature because of low levels of your calcium, obesity, shorted metacarpals and metatarsals, and abnormal calcifications. Now, let's proceed with your laboratory methods. So for your calcium determination methods, we have different specimen that we used. We have your serum, your heparinized plasma, your urine, which is acidified by 6 mol or per liter of your HCl to approximately 1 ml of your HCl per liter of urine. So for your specimen, because of the loss of your carbon dioxide will increase your pH, sample must be collected anaerobically. Kasi nga, pag na-loss ang ating carbon dioxide, diba? Remember, your carbon dioxide is acidic in nature. So pag mawawala ang carbon dioxide, there will be increase ng ating pH. Remember that a change in the blood alkalinity or acidity, it can affect the calcium level. So we have the different methods on determining our calcium. We have your classical method also. You have your precipitation and redox titration using your Clark-Collip precipitation and your ferroham chloranylic acid precipitation. In your Clark-Collip precipitation, we use there will be an end product production of your oxalic acid, while your ferroham chloranylic acid, there will be end product of your chloranylic acid, and both of them will produce a purple color na solution. But this is already a very old method. We have another classical method that we use to determine your calcium. It is your EDTA titration method by your Bacra, Dower, and Sobel. So this is a classic method for determining your calcium and other suitable cations. So the titration with standardized solution of your EDTA, it actually binds to your metal ions in water to give a stable chelate complex. Hence, kaya tinatawag na itong yung complexometric titration method. So we do not technically use this anymore. It's just nice to know this is a classical method. But right now, we do this or we perform this in the laboratory. So we have your dye binding reaction, still your colorimetric method. So your calcium is released from protein carrier and complexes by acidification. So pinatanggal natin yung ating calcium sa protein carrier niya. So using your two method, we have your CPC method or your orthochrysophthalene complex zone and your arsenazole 3 dye. So your CPC, ito yung gagamitin natin sa ating package insert later using your CPC method. It uses your 8-hydroxyquinolone as magnesium chelator, which forms a red-colored complex. So technically, kung piniperform natin to sa ating laboratory, we can really see the changes of the color of the solution. So meron talagang changes sa kanyang solution or color ng solution. But for a more better method, we have your reference method talaga na ginagamit. It's still your AAS. We have also your FEP. We have also your ISE, which is your ion selective electrode, your AAS, which is your atomic absorption spectroscopy. photometric determination. So, these systems may use your membrane impregnated with special molecules that will selectively but reversibly binds to your calcium ion. So, as your calcium binds to these membranes, anong nangyayari? There will be electrical potential na madedevelop across the membrane that is proportional to the ionized calcium concentration. So your calcium will bind to your membrane. Pag bind na siya sa ating membrane, anong nangyayari? There will be electrical potential. At yung electrical potential is directly proportional to your ion calcium concentration. So, dyan yun natin malalaman ang level ng ating calcium level. So, this is basically more sophisticated rather than those mga colorimetric method. But in the laboratory, we do your colorimetric method. Now, let's talk about the package insert sa ating calcium. So, ito yung usually kung face-to-face tayo, ito yung laboratory test na ginagawa natin sa laboratory using your CPC. So, your photometric test for your calcium using your CPC method. Ano po ang principle ng test na to, Doc? So, we use your calcium ions which react with your O-chrysophthalene complex zone in an alkaline medium to form a purple-colored complex. The absorbance of this complex is directly proportional to the calcium concentration in the sample. So your package, your calcium package will contain, mayroon tayong buffer. Sa buffer, you use your lysine buffer and your sodium acid. You also have your different reagent. Ang reagent, anong laman sa ating reagent? Meron tayong yung 8-hydroxyquinolone, your CPC, and your HCl. And your standard, which is purely your calcium and your sodium acid. So how do we make our working reagent? Ito yung paggawa ng ating working reagent. Reagent preparation, we add your reagent to the buffer. Simple lang. Equal volume ng ating reagent sa ating buffer. 1:1 ito. Then, mix and allow to stand for 30 minutes at room temperature before use. That will be our working reagent. So the reagent and standard are stable even opening up to stated expiry date, and contamination must be avoided. So our working reagent, yung ginawa natin na reagent plus buffer, is stable for 7 days with the specific temperature. Ang specimen na pwede natin gamitin, again, your serum, your heparinized plasma, and the stability in serum is 10 days at certain temperature at 2 to 25 degrees Celsius. Sa ating spectro, ito yung ating ginagamit na mga specification. Dapat yung wavelength, it's either 570 nanometer or 578 nanometer. A temperature is around 20 to 25. And again, remember this, measurement against reagent blank. So gagamit pa rin tayo ng reagent. So yung reagent na hindi natin minix ng ating buffer. So yung reagent blank is just the reagent itself. So only one reagent blank per series is required. So how do we test or perform your calcium determination? So yung meron tayong reagent blank. Yung reagent blank natin is purely your working reagent, which is approximately 1,000 UL. So, yan yung ating reagent blank. Remember that, ha? Yung reagent blank natin is purely your working reagent, which is your buffer plus your buffer. It is your, ano nga yun? Your reagent into your buffer. Tama nga. Reagent and buffer. That's your working reagent. That's your pure reagent blank. For the sample or standard, for the sample, you get 20 UL or you get 20 UL of your standard. And then, you mix that to 1,000 UL of your working reagent. So, you mix and measure the absorbance of your sample and the standard against the reagent blank within 5 to 30 minutes. So, again, you mix lang, imimix lang natin yung 20 UL na sample and 20 UL na standard. Separate ito, ha, isang test tube for the sample, isang test tube para sa standard. 20 UL ng sample, 20 UL ng standard. Tapos, dadagdagan natin ng working reagent which is your 1,000 UL. So, imimix mo siya and i-measure ang absorbance ng sample and standard. So, imi-measure mo ang sample and standard against your reagent blank within 5 to 30 minutes. So, after calculating or measuring the absorbance sa ating spektro, anong lalabas na result sa dalawa? Meron tayong absorbance para sa sample and absorbance para sa standard. For us to calculate the level of your calcium concentration, anong ginagawa natin? If we want the result in conventional unit, you just simply multiply it by 8. If we want the conventional the SI unit of our calcium concentration, we multiply it with 2. Pag conventional, multiply by 8. Pag SI, multiply by 2. Anong gagawin, Doc? Yung absorbance ng sample, i-divide ng absorbance ng standard, multiply by 8. So that's gonna be your calcium in conventional unit. Pero pag SI, yung sa absorbance ng sample, i-divide lamang sa absorbance ng standard, multiplied by 2, and that's gonna be your SI units. I'll not give an example kasi very simple lang guys, kasi during the quiz, ibibigay ko naman yung absorbance ng sample and absorbance ng standard. So gagawin mo lang, i-divide yung sample sa standard. Kung gusto ko ng conventional unit, i-multiply mo lang ng 8. Kung gusto ko ng SI unit, i-multiply lang ng 2. So just remember the serum value. The serum or plasma value is around 8.1 to 10.4 in milligrams per DL or conventional. Pero pag SI is around 2.02 to 2.60. So basically, depende sa test na ating gagamitin will be our normal value. Pero for this test, ito yung specific normal value. And also, I want you to remember this one. The test is linear up to a calcium concentration of 15 mg. Anong ibig sabihin nito, Doc? Ang sample test natin is only directly proportional to the calcium concentration of up to 15 mg. So, kung ano nakuha natin na value up to 15 mg, that's already its value. Kaya lang, pag sumobra ito ng 15, kumbaga, ang na-compute ninyo is nasa 16, 17, 18, and more than 15, anong nangyayari? It is not already linear sa ating calcium concentration. Ano ang dapat gagawin? Samples with higher concentration have to be diluted. So, i-dilute mo yun, 1 plus 1 with distilled water. So, yung sample, ratio niya is 1:1 ng sample and your distilled water. Then, you repeat the assay and multiply the results by 2. So, yan yung ibig sabihin na linear, the test is only linear up to 15 mg. So, kung anong value niya less than 15, hindi mo siya kailangan i-dilute. Pero, pag sumobra ng 15, kailangan i-dilute ng water, 1:1, 1 sample to 1 distilled water. Then, you repeat the assay and multiply the result by 2. So, I guess that's very simple. So, for our exam, so prepare your calculator. Again, I guess it's better to review again your parathyroid gland na class natin sa ating endocrine na part because this is a correlation na ng lahat ng ating na-learn sa ating endocrine na parathyroid gland. Kasi nako-correlate na natin yung parathyroid hormone, your calcitonin, and your vitamin D. So, review that again. I guess mga short lang man yun, around 30 minutes. And if you have any more question, please do not hesitate to ask me, PM me anytime. And please review again yung mga sources of error sa ating calcium. You can read that na lang sa ating calcium package insert. Nakalagay yung what are the possible sources of error sa ating calcium. Still, if meron tayong mga hemolysis and etc. So kindly also include that in your reading. So that's it. Please read your Bishop book and your Henry's na book for your calcium determination. So if you have no more question, or if you have question rather, please, I would really appreciate if you ask a lot of questions. So I don't care what time kayo mag-chat sa akin, kahit late night or early morning, just PM me anytime, okay? So that's it for today. It's only a short discussion. So God bless everyone. Thank you and happy Aral.